Okay, so let's talk about the opposite. Let's talk about a fluid volume excess. Right? So again, we call this hyper because it's too much or over what it should normally be, and volemia is volume. So hypervolemia. Again, we split up the causes between intake and kind of output. So it can be caused either by too much intake, or not enough output. Those are the two main categories. When we look at too much intake, this water intoxication, so basically someone drinks too much water. It's pretty rare. You don't see that a whole lot, but it's possible. It's much more likely that a hypervolemia has been caused by administration of too much IV solution. So too much fluids, too much normal saline, D5W, whatever. In terms of causes that are related to intake, that's probably the most common. Now, how else can we have hypervolemia? So let's just look at this here. So we've got a nice little list here of causes. These are the main causes of your body not getting rid of enough fluid or that fluid building up in your interstitial spaces. How does that happen? Let's look at all of these. Let's start with the kidney really quickly. So what does the kidney like to do? What's its job? If you can remember this, it's going to really, really help you in future units. It's happiest when it's reabsorbing. So the blood is coming in, right? The blood is coming into the kidney. It's getting filtered. And then with a bunch of these little nephrons we'll talk about later. And then the body is going to reabsorb sodium and water. And it's going to excrete potassium. This is what makes the kidney happy. That's at baseline what it wants to do. But if there's something going on in the kidney, it's not working as well as it should. These fluids that are coming into to be filtered don't get filtered. They can be, look at it like they're getting blocked off. Only a very small amount of them are going to be filtered, and so this blood actually backs up into the system, and you get a buildup of blood in the vessels, the blood vessels. And what happens again when you have this buildup of fluid inside the vessels, inside one compartment, it causes hydrostatic pressure to increase in that compartment, and eventually it will push that fluid out into your interstitial spaces. And so you end up with edema, right? And when we're going to talk later about, very, very soon, about manifestations. That is really your biggest kind of clue that someone's hypervolemic. The same thing can happen with the heart. You have blood coming in to be pick up oxygen and then be filtered back out. We're going to talk about both of these things in much more detail in separate units. But again, think of it like it's not working, so it's backing up. The blood is backing up. It's not being pumped as quickly as it should be, usually because of congestive heart failure. And then we have hydrostatic pressure building up, pushes out into the interstitial spaces, and you end up with edema. Same is true for liver. It's a little more complicated with the liver, but think of it very, very similar to this. The blood is not being filtered; it's backing up in the system. And so, as opposed to having too much water coming in that's causing hypervolemia, we have the normal amount of water coming in, but it's not being filtered, and it's building up inside of our circulation. This SIADH, you have your syndrome of inappropriate antidiuretic hormone. This will come up quite a lot when you are prepping for your NCLEX. what you need to understand about it, it's almost easy to understand it just from the name. So I'm just going to erase so that I can, if you're somebody who just likes to memorize, go ahead and just skip forward. But I like to understand. So let me just show you really quickly. So SIADH, you remember what antidiuretic hormone does, right? If you just look at the name, it's against diuresis. What's diuresis? Diuresis is the movement of water or fluids outside of the body, often through the kidneys, but also through pores. That's why sometimes your patients who are diuresing will, you'll have fluid buildup. You'll have to change the bed sheets 100 times and so on. And so this is diuresis, right? Getting rid of water, pushing water out of the blood is diuresis. So what do you think antidiuretic hormone does? It stops that from happening, right? It works against that. If we're not having that, then where's that fluid going? It's not leaving the body, it's building up inside the body instead. And so when we have the syndrome of inappropriate antidiuretic hormone, I always think of it as too much antidiuretic hormone, and it's causing a buildup of fluid inside the body. The opposite to this is diabetes insipidus, causes the opposite thing. We'll talk, actually you probably don't talk about it, but it's just note, you do need to understand kind of SIADH versus diabetes insipidus. When you go to study for your NCLEX, just scribble that down. It's a 2-second, once you look at it once, you'll be able to remember. It's not a big deal at all, but it's usually not in school content, but then it comes up at NCLEX and people are a little bit thrown. But in this case, all you need to know is this causes fluid retention. Again, with diagnostics, we're usually using manifestations more so than blood work, but the blood work is supporting that diagnosis. And it's also when our blood work comes back and a patient's sodium is, 125, okay, they're dead, 130, we want to know why, right? And this is that same concept of you have so much fluid, you have so much solute, in this case sodium, because sodium is the most prevalent cation in the blood. If you suddenly have, so if you've got 100 inside here, you've got 135 millimoles of sodium in each liter. If we then increase how much fluid is in the body and we don't increase the sodium, what happens is that ratio becomes much lower. We still only take a liter. We're measuring per liter. So now we only have, let's say, and it doesn't go that drastically, but now say when we measure it, we have 130 millimoles per liter because the percentage of sodium to fluid is lower because we have so much fluid. And so we end up with, it's called dilutional hyponatremia. Hyponatremia gives us a clue, and we're going to talk about this, I think, in future slides, but hyponatremia can also be caused by low sodium count. I mean, someone can have low sodium. And so that's why we have to look at the whole picture, not just, oh, the patient's blood work came back and their sodium is 130. Well, that could mean they have low sodium, or it could mean they have too much water, and we have to figure out which one it is and treat which one it is, right? Again, with the osmoles, osmolality is measured by the particles in that blood. Those particles are sodium, so the low osmolality is explained by this as well. So you can go and measure and memorize if you want, but it makes much more sense this way. We talked earlier on this slide about fluids backing up and causing edema, and that's really the main manifestation of fluid volume overload or hypervolemia, is some kind of edema. So depending on where that fluid has backed up, and that depends on the cause, you will have different kinds of edema. But any kind of So if we've got, let's say CHF, for example, especially left-sided heart failure, that fluid is going to back up into the lungs, right? And so you can end up with pulmonary edema. Pulmonary edema is gonna manifest as shortness of breath. Patients can have a hard time breathing. And also, which these two are a difficult time breathing and shortness of breath, very similar things. Crackles. Crackles is a really, really important kind of piece of diagnostic information. Crackles in your lungs, in your lung bases, is indicating that there's some kind of fluid in your lungs. And again, when you put that together with other information, it's going to tell you something, especially very coarse crackles, and you'll hear the difference between a coarse crackle and a fine crackle. And it's just indicative of fluid. And that fluid has backed up into the lungs because we have too much fluid in the system. And usually because from left-sided heart failure. Again, it can back up into the brain. Really what you're looking here, because these kinds of symptoms and these kinds of symptoms are very generic. They're very hard to that could be a million things: irritability, confusion, depression, whatever. It's good to know that can be caused by hypervolemia, but what's really important here again is this edema along with this increase in blood pressure. We talked about what happens when our fluid volume is low, what happens to our blood pressure, it drops. Well, you have the exact opposite happening when you have hypervolemia. You've got too much fluid in there, your blood pressure is going to go up, your heart's trying to pump it all through, and so you end up with these kind of bounding pulses and this increase in your blood pressure. So you put kind of all of this together with your blood work as well, and that gives you the whole picture to diagnose hypervolemia. And how do we treat? Again, you're going to have to just double check with your prof, because most of the time first line treatment for hypervolemia is to use a diuretic. Don't see that on your slides anywhere. Most popular for quick furosemide or Lasix. That will cause your body to basically pee out all of the extra fluid. Let's walk through what they have here. So if you have a buildup of fluid restriction is a really, really smart thing to do, right? So that's a huge treatment for especially patients with chronic kidney failure, heart failure, whatever. Most of or all are on fluid restriction. We don't want to add fluid when someone's already having a problem with too much fluid. That's common sense, right? We could increase sodium level, or that's not very popular. It's pretty rare that an increased sodium intake is going to make enough of a difference, right? But it's good to know what would that do, right? You have to think it through. And maybe this hypertonic solution, it's you have to have pretty severe hypervolemia, and there are specific cases in which we would use hypertonic solution. But let's walk through, why is it saying used with caution? So, and again, if you're a memorizer, you can just move right on past and just memorize this slide. For everyone else, just walk through what would happen if we give a hypertonic solution. So again, this is our blood vessel. Out here we have our interstitial spaces and our cells and what have you. And out here we've got a lot of fluid, which means our solute inside of there is going to be low. So whatever's in here is pretty low. Lots of fluid, and the ratio of sodium to that fluid is very, very low. If we give into the blood, we give a solution that is fluid. First of all, think that through. We have too much fluid in the blood. In order to give a hypertonic solution, we still have to give fluid. So that's part of the reason it's used with caution, because the reality is we're giving fluid to someone who has too much fluid in their body as it is, or who isn't filtering that fluid properly as it is. That's a big deal, right? If we give a hypertonic solution, so now we've got all these, lots and lots and lots of usually sodium, what's going to happen? It is going to pull fluids out of the interstitial spaces, right, through oncotic pressure. It's going to pull that fluid into the blood system. It'll pull out of the cells, and it'll pull out of the interstitial space into their circulatory system. And then what happens to that fluid? That fluid has to go somewhere, so it's going to go eventually to the kidney to be flushed out. So in order for this to work, your kidneys need to be functioning well. Oftentimes patients who have hypervolemia have kidney issues, right? Because we talked about that can be a cause for hypervolemia. So we have to be very, very careful about that when we're giving a hypertonic solution. The other thing that we need to think about when we're giving hypertonic is, I said that it pulls out of the cells. One of the things we need to be really careful about is that the neurons, right? I'm going to draw a terrible neuron with an X on. Remember that we're hypervolemic, so this neuron is full of fluid and it's not working properly. Maybe it's ready to burst, and we give a hypertonic solution into the blood. And yes, it's going to pull fluid into the circulatory system, which is what we want, because we need to get some fluid outside of this neuron. But unfortunately, we don't have a whole lot of control over how much of this is happening. And what can happen is we can actually basically pull too much fluid out of there and cause this neuron to either die, or we can cause a permanent disability. Just remember that neurons don't revitalize or whatever as well as other cells. So yes, we can use a hypertonic solution, but we need to be very, very careful about it. And really, our first line is going to be a diuretic. I'm thinking that I must be missing where you guys have gone over diuretics or somewhere else.